Nice to see everyone here. Thank you very much for joining us. It's my honor to introduce to you our two wonderful speakers today. The first is Dr. Cecilia Sorensen, who's an emergency medicine physician and the director of the Global Consortium on Climate and Health Education at Columbia University, in addition to being an associate professor of emergency medicine at Columbia's Irving Medical Center and an associate professor of environmental health sciences at the Mailman School of Public Health. We also have Mr. Jeff Schlegelmilch, who is the director of the National Center for Disaster Preparedness at the Columbia Climate School, in addition to being an associate professor for professional practice and climate, and the director of executive education and non-degree programs for the Columbia Climate School. Without any further introductions, we'd love to turn it over to Dr. Sorensen to get us started.
Thank you so much, Ryan, and the whole organizing crew. Really great to be with you today. Excited to talk with you for this hour. Have a conversation about climate change and disaster medicine. I'm an emergency medicine physician, and so I guess I sort of deal with small disasters on a day-to-day basis. And in my time when I'm not in the emergency room, think about the bigger disasters, I would say, that are facing various parts of the world, facing our hometowns currently. So if you give me a second, I'll share my slides here. I want to start by just giving a little bit of a background overview in terms of kind of how I think about climate change and health from the perspective of an emergency medicine physician, and then talk about the work that we do at the Global Consortium on Climate and Health Education, which is a small piece of, I think, the solutions to some of the larger problems facing the climate, facing us related to climate change. So I kind of think about climate change this way, right? You know, we're living in these very unprecedented times, and I'm fairly early in my career. I finished my residency training about 6 years ago. And I remember when I first started doing research into the health impacts of climate change, it felt like it was going to be something that happened in the future. And I have to say, you know, every day, I feel like we have underestimated the real risks, and very much more conservatively put estimates on when these impacts are going to start occurring and impacting the health of ourselves and the people we take care of. And we're sort of in this paradox, so the situation where, you know, we're really the first generation to feel the impacts of climate change, and we need to act urgently now, right? We're kind of this last generation that can really make a huge impact in terms of the direction in which we go related to climate change and health. You know, when I was young growing up, right, the poster child for climate change was the polar bear on the iceberg, right? It was something that was happening far away to non-human creatures. And we know more and more, we're seeing that this is actually something that is happening in our backyards, in our clinics, in our emergency rooms, affecting children, affecting people all over the world, right? And so this shift in this lens from something happening far away to happening right here, right now in front of us, is happened really in the past 5 to 10 years in terms of what we're doing about it to react. And the Lancet came out with this special issue. This was back in, you know, the early 2000s, and they said, you know, climate change is really the biggest global health threat of the 21st century. And the World Health Organization has said similar things. But the reality is that as we think about solutions and ways to tackle climate change, it is simultaneously an opportunity. And we have to think about that. We have to think about how are we designing and adapting our health systems to be more responsive to needs of at-risk populations, and how are we building systems that are not damaging the planet, damaging natural resources as we seek to care for the health of people. So just to give a brief overview of the impacts of climate change on health, and I'm sure many of you are familiar with this, when we think about climate pressures, what we're talking about are increased temperatures, more extreme weather, rising sea levels, and extremes of precipitation. I kind of think about these as the pressures resulting from these accumulation of anthropogenic greenhouse gases. Now, these climate pressures result in what we think of our exposure pathways. Those are things like extreme heat, air pollution, water contamination, changes in vector ecology, increased allergens, food supply and quality, and population displacement. And as a result of these exposure pathways, we get health outcomes, right? We get health outcomes that we see in patients coming into our emergency departments every day. Exacerbations of asthma, cardiovascular disease, strokes, heart attacks. This is resulting from similar types of exposures resulting from climate change. We're here talking about disasters today, and I want to bring your attention, and I'm sure Jeff can talk a lot more about this, in terms of what we are seeing right now in the United States related to weather and climate disasters. So NOAA, our National Oceanic and Atmospheric Administration, tracks what they call billion-dollar disasters, right? These are disasters related to weather or climate that cause more than $1 billion in infrastructure damage, right? This is not even accounting, though, for the health impacts related to the damage that happens in communities, right? And so what we can see looking back at 2024 is that there were 27 separate billion-dollar weather and climate-related disasters that impacted the United States. So it's not our imaginations. There are more and more disasters happening. And this is just looking at the US, and apologies for those of you who are joining internationally. I know there's good data there as well. Again, looking at US data, right? Going back to 1980, right? There was a lot less of this type of weather and climate related events happening back then compared to this graph only goes up to 2022. But what we see here is that a lot of this increase is as a result of severe storms. It's coming from wildfires. It's coming from droughts. It's coming from flooding, right? So we're seeing more and more disruptions and disasters related to aberrations in our climate. And so just to give a few examples, for example, we know that the proportion of hurricanes that become major hurricanes is increasing in most ocean basins. And that's as a result of many things related to the climate, including warming temperatures. So warmer air holds more moisture, resulting in these really extreme precipitation events that happen. We also see rising sea levels and greater storm surge, right? We're also just seeing more heat energy being trapped in hurricanes and tropical cyclones. And so as a result of this, we're more likely, hurricanes are not caused by climate change, but the chances of them becoming major hurricanes, much of this is being driven by changing climate patterns. Another example is thinking about extreme precipitation and flooding, right? And this has become a huge issue, not just in coastal areas related to tropical cyclones and hurricanes, but also inland areas, and thinking about riverine flooding, thinking about the Texas floods that we saw in the US, thinking about the floods in Brazil and floods that have been happening all over the world. So the First Street Foundation, which is a group here in the US which studies this, we sort of have been tracking for years, where flood zones occur in the United States. And we have these 1 in 100-year floodplains, and we have these 1 in 500-year floodplains, which historically meant that the chances of there being a flood there was, once every 100 years. But now what we're seeing is that these 1 in 100-year flooding events can now be expected to happen once every 8 years. And so that's a huge deal. So climate change, again, flooding is a natural phenomena, but climate change making it just that much more likely to occur and that much more likely for it to be more intense, right? So what happens when these climate-related events happen, right? Well, they affect individuals living in communities, and they also affect health systems and our ability to deliver healthcare. Here we're looking at floodwaters rushing into the emergency department of a hospital. Here we're looking at Bellevue Hospital, and it took months for it to repair after Hurricane Sandy. Right. And thinking about supply chains, right? After Hurricane Maria hit Puerto Rico, where many of our IV fluid bags are made, we couldn't prescribe or give IV fluids in hospitals for like months after this hurricane, right? So it affects supply chains. It also affects our delivery of care. Another area which I think is slightly less appreciated about climate, if we look here at sort of this graph of the Internal Displacement Monitoring Center, this is old data, so I apologize for that. But if you look at the total number of new displacements, people forced from their homes, just in the year 2020, there were 40 million people, right? And about 10 million of those were due to conflict and violence. The other 30 million are due to disasters, right? And we think about weather-related disasters. So those are droughts, extreme temperatures, landslides, wildfires, floods, right? These are climate-related events that are causing massive human migration, right? So this is a big issue that's becoming more and more prominent in our lifetimes as we think about how can we humanely respond to forced migration and think about how can everyone on this planet really secure a stable and safe livelihood for themselves and for their children. And climate change is making this ever more difficult to do. Right now I'm sitting in Colorado, and I've been breathing in wildfire smoke for the past 3 weeks due to unprecedented wildfire events in Canada, as well as in Colorado, California, and the West, right? These things are climate related, right? There's evidence which suggests that roughly 50% of the extent of wildfires, which we're seeing today, can be attributed to climate change, right? And the results of that, we are just beginning to understand what the long-term impacts are of wildfire smoke exposure. But we know they're not good, right? They affect your lung health, they affect your cardiovascular system, and ultimately they're going to impact vulnerable populations first and worst. And those are people who have no ability to really protect themselves because they don't have proper housing, or people who are older and have chronic conditions, which make them more vulnerable to get sick when they get exposed to wildfire smoke, or the very young and also pregnant women and unborn children also have really detrimental impacts as a result of wildfire smoke. And so as we're sort of thinking about all these different exposures, we're thinking about increased risks of disasters and how we're going to sort of cope with these types of issues in the future. What my work does is think about, how can we leverage the expertise of health professionals to work in this space, right? So at the Global Consortium on Climate and Health Education, our real mission is to try to equip health professionals with the knowledge and skills that they need to be able to respond to disasters and climate impacts in the communities where they serve. And if you think about health professionals, right, we collectively have an incredible impact or potential incredible impact, right? In addition to being private citizens, many of you here will go on to be institutional leaders. You are trusted community voices. Many of us might become researchers, clinicians, right? And in all these different roles, there's ways that we can think about how we adapt our practice to make it responsive and make it proactive to the health impacts of climate change that are happening, whether noticed or unnoticed in our communities. So just kind of thinking about, if we could write prescriptions for what health professionals can do, one thing that we urgently need is the undertaking of healthcare climate vulnerability assessments, right? This is understanding which hospitals where we practice are vulnerable to the health impacts of climate change. Do we have backup generators? Do we have plans for evacuation? Where in our communities are vulnerable patients located, and what is the plan to reach them should there be an emergency in our community? Many of these plans for hospitals are retrospective in terms of how they're designed, and they are not necessarily accounting for climate risks, which we project are going to happen in the coming decades. We also need to think about how we understand the evidence base, right? How do we know what the health impacts of climate change are, right? I was talking recently about wildfires. We know what the short-term health impacts are, right? It drives people into emergency rooms because of respiratory disease exacerbations, because of strokes, because of heart attacks. But what happens in the long term? Well, we don't know, right? And so a lot of our work of our generation is to understand these connections and furthermore understand what we can do or what people can do and health systems can do to prevent these impacts, especially among those who are most marginalized. The other thing I always think about in terms of what clinicians can do is how do we create, update, and adjust health guidance and treatment standards so we can diagnose and treat anticipated health burdens from climate change. As an ER doctor, one of the things that I've been doing in this space is designing heat stroke protocols, right? So when a patient comes into the emergency department and they have heat stroke, which is a very time-sensitive condition with a lot of resources that need to be mobilized very, very quickly, we need to have a protocol for that, right? It's like anything else that we do in medicine that requires very, very timely delivery of care with a lot of complex steps. And so these are things that we can do as health professionals to improve care in a changing climate to reduce health impacts. I would say another example of this is how we really train for these system-wide issues. And this is the example of the emergency management of heat stroke protocol. And we've turned it into a sim case at our residency training program in emergency medicine. So we can really be thinking about this ahead of time and be practicing how to rapidly identify and how to respond to these types of climate-related health events. Another area that I think we as health professionals need to work very urgently in is advocating for and leading healthcare decarbonization efforts in our departments, in our institutions, as well as in our community levels. So many of you know this, but if the global healthcare sector were a country, it would be the 5th largest emitter of greenhouse gases on the planet. So we do a lot of good in the communities which we serve. There's no doubt about that. But we have 24/7 operational demands. And there's a lot of waste in healthcare, right? And I'm sure many of you have seen this so far in your career, right? The reality is that we can do what we do better and make less waste and use less energy and achieve the same health outcomes. And if we do that, if we use less resources, if we are more judicious about how we spend energy, the reality is that many hospitals can save money. So what does it take to do this? It takes political will, and it takes health professionals putting pressure on their administrations, on their institutions to work towards decarbonizing their health systems. There was a really great pledge that was going around a couple of years ago in the US, which has since been taken down off the government website. But we did have roughly 15 to 20% of US hospitals which had pledged to work towards decarbonization. And the reality is that the upfront investment pays for itself and also reduces costs for healthcare delivery. So we have jobs that we need to do in adaptation and in mitigation to reduce the health impacts of climate change now and in the future as health professionals. Last but not least, we have to think about how we educate ourselves, how we educate our patients, and how we educate our communities, right? This can come down to something around, Thanksgiving dinner, right? People look at you because you're a health professional. People ask for your advice all the time. And when things come up related to climate or climate-related events, you actually can become a source of vital, accurate information. There's many resources out there to talk to your patients about these types of things, talk to your communities. And what I recommend is sort of understanding what the climate risks and exposures are in the places where you work, and becoming familiar with what resources are available so you can guide patients and people in your community in a good way. So I'm just going to wrap up here really quickly talking about my work at the Global Consortium on Climate and Health Education. I came to this work with a background in emergency medicine, but also in a background working in humanitarian disaster-like situations, and understanding that one of the most powerful tools that we have is educating each other, right? And what a huge difference that can make to have educated and trained health professionals everywhere in the world. And so the work that we do at the consortium is to work with existing organizations to upskill health professionals to understand the health impacts of climate change, understand how disasters are affecting populations, and furthermore, understand what we can actually do about it. And so we work across various pillars of work. I'll talk briefly about them here. At our heart, we are a membership organization. We have right now 420 health professional training institutions from 70 different countries. You can see a map of all our members here. And this means that that institution is pledged at the level of the dean or head of school to train their students in climate and health, which is an incredible pledge. And through all these pledges, we reach approximately 300,000 health professional students annually. And so what our work is on the background, on the back end, is to work with faculty, work with schools to make sure they have the curriculum that they need, the resources that they need to really deliver the best and most timely climate and health education for health professional students. And that's really the heart and soul of our work. We also have a lot of partners, over 150 NGO and government partners who work in concert with our secretariat based at Columbia University and our institutional members across many different countries, just a smattering of their names here. As part of our work, what we do is we develop core competencies. So these are the things that we hope all health professionals will understand about climate change and what they can do to make changes in their community. We have tons of resources available. We offer a lot of free courses. So I'll put my email address in the chat after this and the website. You're welcome to sign up. We offer free certificate-based courses now in all 6 WHO regions. So there should be a course coming to you soon. If not, there's already one up on our YouTube channel. We also do a lot of work with governments, with intergovernmental organizations, do a lot of consultancy work, thinking about how do we build capacity, for example, within development banks, within the Pan American Health Organization. How can we, climate-proof operations of these core organizations that really support health throughout the world, right? And how can we help them improve their education delivery? We also do a lot of work around policy and advocacy. We work to build technical capacity within health associations. We advocate for the inclusion of climate and health on professional exams. We participate in a lot of working groups. Here's just a smattering of some of the associations we work with. Some of the work that we do, which is closest to my heart, is our work with communities. We find that community members, as you all probably know, are just so incredibly important when it comes to the health impacts of climate change. And so we have several programs right now focused in India on extreme heat, and then focused on building disaster resilience in the Dominican Republic. So that's a little bit of our work. I wanted to give you a little bit of background on climate change and health. And with that, I'll turn it over to Jeff. Thanks so much.
All right, thank you. Oh wow, that was really
Whirlwind.
incredible. No, that was great though. I'm so glad you went first. Takes a lot of pressure off. Great to see everyone. Great to meet everyone. Let me share my slides here. My name is Jeff Schlegelmilch. I'm not a doctor, but I do take your insurance. And that joke is even funnier in an American healthcare system. Okay, among my various roles, I lead the National Center for Disaster Preparedness at the Columbia Climate School. We had actually started at the Columbia, the Mailman School of Public Health under some public health preparedness training centers that were set up in the post 9/11, post anthrax attack days. I actually got my start as an epidemiologist and a public health planner. And that perspective is something that I've really sort of carried with me. And I'll talk a lot about sort of why when we talk a little bit about the complexities of climate adaptation and what that means both from health as well as sort of the broader civil society ecosystem. We really focus on areas of systems readiness, disaster recovery, citizen engagement, and vulnerable populations. Our center was founded by a pediatrician and children's advocate, Dr. Erwin Redlener. So it's always been a very sort of special part of the work that we do. And I always like to say in some cases, we're conducting original research, but in all cases, we're looking to translate that research, whether that's into policy, whether that's into training programs, whether that's into decision support tools, things like that. So I'm going to focus on a couple of things that all stem from sort of this basic sort of premise, which is that, a lot of times when we think about risk, we think about this exposure to the hazard. And we look at like, well, how close are you to the water? How close are you to the winds? Or as Dr. Sorensen mentioned, how close are you to the wildfire smoke, right? And we know that that's one part of it. But in actuality, our risk to a hazard our risk to a disaster is this formula from UNDRR, a hazard times vulnerability divided by the capacity to cope. I did a lot of work with electric utilities, and we can take the same city and we could take an intervention that keeps the power on in the event of a mass outage for 10,000 people for 48 hours. And the current formulas, or at least they're trying to change them now, but the current formulas are agnostic. It doesn't matter which 10,000. So for those who are familiar with New York City, we can put those 10,000 in the very affluent Upper West Side or in a historically disadvantaged area like the South Bronx. Now, we all know, right, that you would have very, very different outcomes from all of that. You have higher rates of chronic disease in areas that are more economically depressed. You have older housing, which means greater exposure to environmental hazards and heat and cold, depending on what time of year it is. So greater employment instability, more people who you don't get paid if you don't show up to work, right? I'm fortunate I have generous sick leave policies. I can miss a few days of work and still get paid. So these are all things that factor into that capacity to cope. And so when we think about risk, we really have to look at it across all of these continuums. So I'm going to talk about two projects we have in process, one in its infancy, which I'll share with you today, and then another that's actually been deployed that are trying to understand through this lens of this risk formula of hazard times vulnerability and capacity to cope. And I say that my background in public health has been essential for this. And I say this because you're really in a great field for understanding this, because you really have more of the tools than in any other field, because we already have this. We already have this with social determinants of health, with how sort of the environment the patient exists within affects the likelihood and the conditions and the treatment regimens when they come into that front door of your facility for treatment, and how to ensure maintaining health as they exit that facility. So this first one is called the Disaster Genome Project. And the idea behind this is that we have all of these different interrelated variables in the event of a disaster. And we've been thinking very two-dimensionally about these. We've been thinking about, oh, you're close to the hazard, let's move you away from the hazard. And what we don't do is we don't look enough at the interrelatedness of all of these different variables, but we have enough research now, we have enough to draw upon to start to map this out. And so what you see here is this very elegant, and if I bring it into a different application, I can show you some cool animations and still not make much sense. But let's break this down. We have this broken down by hazard and exposure, the social environment, public health, including health and medical, epistemology, getting more into the philosophical, and how we frame the world around us, governance, economics, disaster risk management, agri-food systems. So if we just drill this down and we just look into areas, and the other thing is the thickness of the lines, so these were all drawn from the research, from the literature review. And so the connection points represent how these variables are related to each other. And the thickness of the line is the number of publications behind it. So the thicker the line, the more we've seen this connected in the evidence base. So let's start, and I will say this is in its infancy. This is just in its prototype. Obviously, this is not exhaustive. But if we look at public health, we look to preventative care, we look at health services, there's a strong linkage there. We look to mental health, but we all know this is not the whole story, right? Public Health 101, social determinants of health, it looks more like this, right? The relationship of public health and the experience of someone living a healthy life or not a healthy life is heavily influenced by social structures. You see a very thick line between public health and social, disaster risk reduction, geographic location, health services, governance, the disaster type, insurance. That's why my insurance joke is more funny to some than others. Warning systems. So these are all factors that sort of link to the experience of health that exist in domains outside of the clinical, outside of the public health, but have a significant influence on that outcome. So again, I think that training within public health to sort of look at the whole of society can make the problem very overwhelming, but also make it more realistic in terms of the variables that need to be adjusted. And so when we think about this in the context of climate change, we have policymakers, we have community-based organizations, we have finance professionals, end users who are all sort of trying to pull from the research and pull what they want to do. And it's sort of a messy, I have another graphic with squiggly lines sort of going between these. But essentially what we're trying to do is we're trying to get to a better place of trying to harness the power of the research that we have to inform the decisions that we need to make. Big caveat here is we have more information than we're currently using. We don't have all the information on everything that we need. There are a lot of blind spots in the research. There's, what is that saying? Absence of evidence is not evidence of absence. That being said, to better triangulate research, to better optimize it for the types of questions that we face. So where we're at right now is starting to build the back end and then the front end of this, a climate adaptation support tool to help bring really a synthesis of the state of the science that's more mapped to the questions that people will be asking, as well as tools like case studies and practical guides. These are areas where I think artificial intelligence and advanced analytics and machine learning can provide a lot of value to this kind of a problem. A lot of times it's being used to sort of fill in the gaps of what we don't know. And I'm very worried about that because disasters are tail events. They don't happen very much. And there's a lot of gaps in the research. But to better harness the information that is out there, I think there's a tremendous opportunity to think more three-dimensionally and get more robust answers. All right, so I mentioned that that's in its infancy. Let me get into one that we've actually deployed, that's actually out there. And this is our Climate Finance Vulnerability Index, the CLIF-VI. And you can get to it by clifvi.org, no dash. And this is available now. So the idea behind this really came from this question. We're looking globally at climate adaptation. We're looking at countries that are getting hammered. Dr. Sorensen shared with you some of that data. For the US, the global data looks exactly the same. It's just the numbers are bigger. But you see similar hazards. The dollar amounts are less in certain parts of the world, but the proportion relative to the overall economy still remains very high. So there's also some inequity in even how the data is displayed, right? You'll see countries like the US that if you're looking at the cost of disasters is the highest, but if you look at the proportion of GDP, it's actually many, many more lower income and lower middle income countries. But the idea here behind this was this question that if we're going to start seeing more and more outflows of money from the World Bank, concessional finance lenders, things like that, where is that money poised to do the most good? And so we created a relative ranking looking at countries around this idea of climate adaptation. And we looked at it across two axes, climate risk and financial vulnerability. So the first question we ask is around this: who needs help when it comes to climate adaptation in the form of concessional finance? Then that gets broken down into a few questions here. On the x-axis here on financial vulnerability is what is the access to finance that already exists? And I'll go over that in just a minute. And on the y-axis is what is the risk of impacts from disasters? And then separate, it's not directly calculated in the index, but we ask this question of okay, so you've decided to finance, what are some of the considerations? So we have a separate analysis of governance. We didn't want governance to be reason to or not finance, but it's an important part of how to finance. So let's click on a country, and I like using India as an example because India kind of defied expectations a little bit. And I'm going to be honest, it actually forced us to make sure we were doing this right. And I say this because India scored pretty well. Everything within this index, lower is better, higher is worse. So India actually ranks in the top 20. And so you can see it's got a number of hazards it's exposed to, but does relatively well in financial vulnerability and in climate risk. And so we asked ourselves, does that make sense? That doesn't feel right. Let's dive into it. So if we look at India as a country, it's very exposed to multiple hazards. It's really very exposed to virtually all hazards at a very high risk. You'll notice among these hazards, we also have conflict and epidemic, because those are things that have indirect relationships, but very strong relationships to climate change. We expect more state pressures from the issues of climate migration, as well as the epidemic pressures for a variety of reasons that Dr. Sorensen touched on. These are retrospective data sets. They're retrospective because the retrospective data is much richer. We look to the right, we look at the climate projections. In this case, we actually see India having not much of a change or even a slight benefit under some of the climate change models. Now, I say this with caution. This index is 50-50, 50% retrospective, 50% prospective. Part of that is that the forecast models are incomplete. This covers 4 or 5 different scenarios. It does not cover things like tropical cyclone wind speeds, which the models aren't good enough yet. Even among modelers, there's disagreement. If you think watching epidemiological modelers fight it out at a conference is entertaining, go to a climate conference and watch climate modelers fight out over methodologies. And the important thing is just to note that these are young. This is a very young aspect of the science. It's also the data is very limited. I mentioned disasters are tail events. They don't happen every day. Even though we're seeing more of them, we're still not seeing thousands of them a day, like in other branches of engineering and things like that, where you can really evaluate and develop robust models. Another key area, and that's why we cover population below 5 meters, is because of the pixelation for sea level rise. A lot of small island developing nations are smaller than the pixels. So we do 50-50. We do 50-50 because we want to capture the data on historical hazards, which are a good indicator of the baseline level of risk, and then look at how much that is going to change. So that's half of the score right there. And it's still fairly elevated in terms of, oh, excuse me, this is not half of the score. This is part of that half of the score. Then when we get into the rest of the climate vulnerability score, remember that formula earlier, risk equals the hazard times the vulnerability divided by the capacity to cope. So if we look at the hazard score is quite high. If we look at vulnerability coping capacity, that score is quite a bit lower. And if we look at the breakdown, this is all coming from the informed data sets from the European Union. We see massive investments in disaster risk reduction and physical infrastructure. Access to healthcare is a key indicator, of coping capacity of a population. Vulnerability dimensions, inequality, uprooted people, economic dependencies, these all score relatively well compared to the rest of the world. This is not to say that India does not need support. I believe every country needs support. I believe all climate adaptation finance should be concessional. This is just a relative ranking compared to other countries. These investments have paid off. These investments have created an environment of reducing risk, and may actually make the case for more investments, that it's going to continue. That's up to the financer on all of this. So that's half the score. That's why we see it lower on that y-axis, right? Even though we have a very high hazard exposure, we have not big signals on the climate change, which may not be totally accurate. They're limited by the models as they are today. But then we see them making up a lot of ground on coping capacity and vulnerability, particularly relative to the rest of the world. Then if we look at the x-axis, we look at things like debt sustainability, financial sophistication, and financial integration. This is another, when we look at this, we look at things like debt to GDP ratios. So GDP per capita has been sort of how much wealth a country has. Now, my mom used to tell me rich people don't have more money, they just have higher monthly payments. I'm not sure how that relates, but I thought I would share that. So GDP per capita tells you, how much money is coming in and divided by the number of people. What it doesn't tell you is actually how much access you have in the bank account, or how much lines of credit you have access to pay for climate adaptation, to make investments in infrastructure and public health and things like that. Debt sustainability has to do with things like what is the level of debt? When are those payments due? This looks kind of high here, but that's actually fairly average, if not a little favorable compared to the rest of the world. Financial sophistication is the size of the internal markets. India has very robust, very sophisticated internal capital markets that it can access. And then financial integration is the integration with the international markets. So there's a lot of there are a lot of places to go for traditional finance to help fund these things, which is why you see it so favorable relative to the rest of the world on that financial dimension. And then we look at this over time to see if that's relatively stable or something that's changed a lot over the years. So again, we're trying to match the data with the question. Similar to the Disaster Genome Project, the idea here is that we cannot create one data set to rule them all, but we can take structured data that's already out there and optimize it for the decisions we need to make. The other thing I would say is if we're looking at what to fund, so you've decided to fund, well, there's a whole number of disaster risk reduction interventions that could be prioritized here. Here, it's less of an issue, but if we saw the country being driven, we see a lot of small island developing nations really pulled to the right on this graphic on the financial vulnerability. Maybe it's more about debt forgiveness. Maybe it's more about investments in the financial markets to be able to access resources, because once you put up a seawall, you have to sustain it, you have to maintain it. And then I mentioned governance. So at the end of the day, we do track a number of things on governance. We didn't want governance to be something that is a determinant on whether or not to provide funding, but it does matter in terms of how to provide funding. To be very crass about it, if you have a very high level of corruption, you don't want to give an unrestricted blank check, right? There may be other issues in terms of capacity, the capacity to manage grants of that nature or things like that. So maybe you're better off working through a multilateral institution with technical assistance embedded into that. So again, the idea through this, as you click on a country and work your way down, is to help inform those decisions and provide more richness. The only other caveat I would give is the data only tells you what the data tells you. It's not the complete story. It's never the complete story. This is meant for decision support, not decision making. And the idea across all three of these is that climate adaptation is a multifaceted problem. And circling back to Dr. Sorensen's presentation, this is interrelated with all different aspects of civil society. We can't focus on just one without recognizing the relationship between the others. In some cases, we may have unintended consequences of the pieces we're not looking at, and that may diminish the value of what we're doing. And in other cases, it may enhance the value. It may have benefits that cascade across the system. And so in embracing that complexity and building a more holistic view, we create more lasting solutions. And there's no better place to start than from the foundations of public health, because at its very nature, public health and medicine has a huge head start in terms of taking that worldview, in terms of understanding the context that the patient comes from when it comes in that front door. So with that, I will stop sharing, and we look forward to chatting with all of you.
Wonderful. Thank you both so much for your wonderful presentations, and appreciate all of you who put notes into the chat and comments that really added to this conversation. I'd like to open it up to the audience for any questions that you all have. Feel free to unmute and ask them over the phone or to send them in the chat. And if there's nothing that comes up, we have a few that we can ask that we are interested in, but would love to get folks from the audience. All right. Patricia Frost, over to you.
Hi, thank you so much for this excellent presentation. Really appreciate it. We were talking about, or both you and Cecilia were talking about how important it is for the collaboration and to get the information to the people who need it. Our organization, the National Pediatric Disaster Coalition, Jeff, you're affiliated with us, have been very at the forefront with these issues, but we are still not getting people as connected as we need to be. For instance, the Pediatric Pandemic Network, the Pediatric Disaster Centers of Excellence, those initiatives that are happening right now. Even though I have done my part as a subject matter expert to help basically advocate for them to make those connections with your organizations and your efforts, especially since you guys both have had such strong pediatric focus. Why are we still struggling in terms of this cross-sector collaboration issue and the barriers associated with that?
That is a fantastic question, and I'm going to dare to answer it. The way we're taught to break things down is in a very reductionist approach. I promise I'm going to get meta for like 2 seconds, and I'm going to bring it back to reality. Right? And even from a young age, we're taught a very reductionist approach to the world. We break things down into different chunks, and then we specialize and we focus on those specializations. Disaster science sort of defies that. Disaster science, I like to equate to music. You get social science, you get medical science, you get engineering, and then you play those 3 notes, and then you hear the harmonics and the discoveries in the harmonics. It's very context dependent. It's very chaotic in nature in terms of these variables and their influence on each other. And we're not well prepped for that. We're not well prepped for that in how we learn science, and we're not well prepped for that in how we structure. We structure bureaucracies, we structure disciplines in a very reductionist approach. My colleague Ellen Carlin and I spent a lot of time thinking about this for our book, Catastrophic Incentives. And so coming up with new models like this, like conversations like these, like the work that you're trying to do, I shouldn't say trying to do, that you are doing, it's just, and are making progress on, is really to kind of not only create a solution in a world that needs it, but to reinvent the way that solutions exist, the way that we think about the world to be to better capture these complexities and these intersections across different disciplines. So I'm not sure how actionable that answer is, but it's an important question and an important discussion, I think, for us all to be having.
Great. Thank you so much for that question and answer. We have another hand raised over to Remy Graber.
Hi, can you hear me?
Yes.
All right. So I appreciated the presentation. I had a little bit of trouble getting in for a moment because I'm driving, so my phone didn't want to patch in. Just from my experiences, so I come from a background of EMS and emergency nursing. I was part of rescue relief during 9/11, part of relief efforts during Katrina, as well as during Hurricane Sandy. And a common theme that kind of popped up in my experiences is that you get organizations that kind of have these little jurisdictional arguments with one another about who's going to handle what, who's going to do what. And I was curious if anyone had any data about any costs associated with that. Like, so for example, during Sandy, there was an argument between Coast Guard and FDNY. While we were working in Far Rockaway with very little resources, trying to get people out of the high rises, especially the elderly, we had an issue of who was going to do what, and either side was kind of budging for a little bit in terms of getting active rescue to get people out of their buildings. Do we have like data or anything that talks about any of the costs of these like small like jurisdictional kind of like I guess like hiccups?
My sense, and I think this is like reported by people in the field, but is not systematically analyzed, because I think it's just tricky to sort of say exactly what has happened. And every disaster is so unique. And I think in best case scenario, you're looking at doing mock drills, right? You're sitting down with all these agencies before a disaster happens, and you're talking about roles and responsibilities. And then you also, I think, have to look at, right, like, as you mentioned, like, where is the funding coming from to equip different teams to be doing different things? I would say this happens in terms of the work that you do. It also happens in humanitarian emergencies, where different organizations are showing up, and somehow there ends up being like turfing types of issues which happen. I don't know. I mean, I have not seen any sort of real analysis of this, or really any evidence of this in the scientific literature, but it is a phenomena that seems to occur. I don't know, Ryan or Jeff, if anybody here has heard more about this.
I don't know that there's been, and man, what a great project to throw McKinsey or BCG or one of these consulting firms at, right? Is to calculate the hourly rate of inefficiency in turf wars. Certainly on the leadership side, on there's been a number of folks. I'm biased towards New York because I'm based there. Joe Pfeiffer, who's former actually commissioner now of New York Fire Department. Talks a bit about this. I don't think that it's been analyzed. To my knowledge, it hasn't been. I'd love to see it if it has, because I'm sure the numbers would be striking. But just a very quick story that he tells is that, they kept trying to get more and more integration of response. So they created a unified command center. So if they're in the field, they'd put them in a parking lot. And what happened is NYPD would go to their corner, FDNY would go to their corner, and all the different jurisdictions would go to their corner, and they would still meet. And and the only time it worked was when they set up the unified command center on a highway overpass that was so small they couldn't separate. So they physically had to work together. So I offer that as an important note too. It's sometimes you have to sort of break through the psychology and sort of create the opportunity for it. But I think it's a great question and a great research project. And yeah, I'd be happy to write that funding proposal with you.
Thank you so much.
Well, on a similar vein to that kind of closing comment there about, opportunities and proposals and funding and opportunities, what would you recommend for any students or residents or faculty members who are here that are interested in getting involved in this kind of work?
It's a great question. I mean, I think, it depends on sort of what profession you're coming from. I would say more and more, we're seeing more and more opportunities for health professional students to do different types of engagements with climate and disaster medicine. So I would say if you have faculty at your university who do anything that sounds remotely related to this, I would say approaching those faculty and seeing what they're up to is a good start. There's a really great organization, at least based in the US, but another one which is more international, called the Planetary Health Report Card, which are groups of students at different health professional training institutions who are getting together to try to understand what institutions are doing about this. So I would say, it seems that on many and an expanding number of health campuses, there are opportunities for health professionals to get involved in this. I think the interesting thing is it's a little bit in some ways, it's out of scope in some ways of what traditional health professional training looks like. But I think more and more it's a skill that's needed. And we're finding that there's more and more sort of hybrid or collaborative training programs, which sort of are emerging at this point. So that's my perspective. But Jeff, curious if you know where the money is.
No, I couldn't have said it better. Yeah, where the money is, who knows these days. But but I think that, there's, as I mentioned with the disaster genome, there's so many different perspectives that come into this, right? And what that value proposition is for someone in the private sector may be very different than someone at a health research foundation or something like that. So on the funding side, we have to be able to articulate value a lot of different ways. In terms of experience, I think anything you can get, and in particular, anything you can get outside of what you would normally get is going to add value. It's going to add perspective. It's going to add empathy. It's going to add understanding. And so I would say that just, the only bad experience is the one where you walk into it with a bad attitude. But there's something to be gained from all. There's something to be learned from all. And so definitely give yourself a chance to kind of step back, experience something different, talk with that faculty that's maybe adjacent to what you're doing, and explore an opportunity that might be a little different than what you expected.
Yeah. And I would say, there's a huge role for research in the traditional academic sense. I think there's also a huge role for getting involved in communities, right? Wherever you are, trying to understand people in your city, people in your town, what their interests are related to anything that's related to what you're interested in, right? And practice sort of working with communities, because if you're working in disaster medicine, you need to work with communities. And so, I mean, I think the more experience you have in that space, the more useful it becomes for you down the road when you eventually do get the grant and you do the research, that you know what it means to be as part of a community. And also it's really fun and rewarding, and yeah, super humbling. So that's my recommendation.
Perfect. Really appreciate those answers. We have a question that came into the chat from Meredith Highfield, and it says, has anyone looked at how modern healthcare would manage if plastic becomes severely rationed, potentially with dwindling supplies of oil being incredibly expensive and commandeered by governments for heavy industry, military use, etc.? We're only a few decades at best from the forecast end of oil, and that means end of plastic. Also, rate of use of oil by developing countries is accelerating. At present, it appears unlikely that oil can be replaced 100% by renewables for heavy industry use, for skyrocketing power use to run data centers, and even for replacement of windmills, solar panels, etc. Over to our panelists for thoughts.
I can, so this came up in a conversation recently because we have a researcher at one of our institutes at the climate school who led the research on microplastics in water. And so folks may have seen that's been well reported on, and it's everywhere. And of course the health impacts are something we're just starting to try and understand. And in that discussion, and this was just kind of in like a general discussion about things. This wasn't a research discussion or anything. It was talked about how, really the last line of where plastics could be eliminated was in healthcare, because there were so many things in terms of creating a sterile environment and things like that. And so I think it brings up a really important point. We see this in climate change too, with decarbonization, things like the steel industry. Steel is so energy intensive that doesn't really currently have a viable non-fossil fuel alternative. Those will eventually come, but we're not there yet. And I say this to say that, and I'm going to say something a little controversial here, that kind of the direction we want to go in is pointed in the right direction, but the speed in which we want to go there may actually create vulnerabilities that cause more harm than good in the near term. I spent a lot of time with this in the electric industry, where the move towards decarbonizing the grid could actually destabilize a lot of highly vulnerable communities, because the technology isn't there to catch up yet. And these are the communities that would see the most morbidity and mortality as a result of frequent and prolonged outages for a variety of factors, most prominently due to health factors. So it's an important question, and I'm dodging around an answer because I don't have one, other than of the conversations I've been a part of, it's been recognized that healthcare is probably among the last that plastics could be removed from with the current technologies. Now, just because we haven't figured out the answer yet doesn't mean that there isn't one. And so there's another great research project there that maybe I'll will take on and get lucrative funding and figure out the answers to.
Yeah, and I would say currently we have a lot of disposable equipment which could be replaced with how we used to do healthcare, which was not with disposable plastics, like up into the 1950s. Granted, there's a lot of things that we need, single-use instruments for, but there are many things that we don't. And there are many things that can be manufactured to be repurposed. And I would say, knowing that if there is to be a shortage, like our goal now should be to think about how can we minimize waste in healthcare? How can we really make better use of the resources we have now, to think about a time when we do not rely on single-use plastics, right? There's been so many interesting things that came out of the pandemic. And, it was sort of one of these moments for those of us looking at decarbonizing and removing waste from healthcare, where we were like, oh my God, like the floodgates just opened up in terms of like every single person putting on PPE and disposable gloves and masks, and then 5 people throwing it in the garbage and going to the, and we're just, and then there was this thing that kind of went viral. It was like, this one health system was like, we don't have the backup gowns and gloves to do this. So basically what they did is they created what they called the red line. They bought like several rolls of red duct tape, and they created a line 12 feet away from a patient bed and said, if you cross the line, yes, you have to put on PPE. But if you're just coming in to like say something, verbal communication, look at a monitor, whatever, you don't have to put on PPE. And by literally just buying some rolls of duct tape, they saved like thousands of pounds of trash. Now, was that scientific? I don't know, right? But the point is that there are ways that we can I think make changes now which are innovative that reduce our reliance on plastics. I would also say that the infection risk is often much overstated. If you look at sort of one place to look at this is the Aravind Eye Center in India, where they do, oh my God, something like they use like 1/1000th of the amount of materials that we do to do a single cataract surgery, like literally, and have better outcomes and less infection rates than we do at the best eye centers in the United States. with like 1/1000th of the resources. So anyway, food for thought.
Anyone out there who doesn't think that duct tape can fix anything, I just want to say.
I'm an ER doctor. We're the specialty of duct tape. Like it fixes everything. I mean, that's all we need. Yeah.
Now there's data to support that.
Perfect.
Well, I think there's no better way to end than an homage to duct tape. But I will turn it over to Dr. Andrew Shanes to just give us some closing remarks before we call it for the night.
Cool.
No, I just want to thank you both so much for joining us again today. This was such an educational talk. I'm so glad that I was able to be a part of it, that we had such a wide variety of our audience members able to participate as well. As always, if you want to stay up to date with future events that we're hosting as the Student Young Professional Special Interest Group, or for WADEM as a whole, you can sign up for our email list. I put the link to it in our chat. And then if you want to stay connected, just in general, or if you're interested in hosting other events, or if you know other speakers that you may think that would be interested, or if you are a student and want to potentially create a WADEM club at your own university, always reach out. We're happy to connect. We're happy to continue all learning together. So once again, thank you guys so much for joining us today, especially to our hosts, and we hope to see you at our next event. Thanks all.
Thanks, everyone.
Thank you.
Thanks. Be safe.